Good afternoon, everyone. Myself, Dr. SANDHYA YADAV, final year postgraduate trainee, here presenting a rare case of gonococcal ophthalmia neonatorum. Introduction. Gonococcal ophthalmia neonatorum usually occurs due to vertical transmission to newborn during delivery by women with Neisseria gonorrhea. Untreated gonococcal ophthalmia neonatorum can result in severe ocular conditions including corneal scarring, ocular perforation, and blindness. Case report. A 4-day-old child resident of Morigaon, Assam presented with mucopurulent discharge from both eyes which was associated with redness and bilateral periorbital swelling since 1 day. There was associated excessive crying, irritability, and poor feeding of child. There was no history of fever, cough, any nasal or ear discharge. There was no history of any ocular trauma during delivery or installation of any eye drops or massage of eyes after birth. Birth history. The child was third child of non-consanguineous parents delivered at term through normal vaginal delivery at local PHC. Birth weight was 3000 gram. Child cried immediately after birth and breastfed. There was no history of any premature rupture of membrane or instrumental delivery. There was no history of any NICU admission, and there was no prior history of recurrent abortions or stillbirths. Past history of parents. Mother gave history of vaginal discharge during first trimester of pregnancy for which no treatment was taken. There was no history of any chronic illness in mother. Only first antenatal visit of mother was done. Father also gave history of off and on urethral discharge from last 1 year, but both parents refused any history of multiple sexual partners. This baby came with us on day 1 with bilateral mucopurulent discharge with mated eyelashes as we can see in the first picture, and there was bilateral periorbital edema and redness. On examination, child was alert, active, feeding well at the breast. The length of the child was 48 centimeter, head circumference 32.4 centimeter. Pulse rate was 116 beats per minute, respiratory rate was 34 per minute. On ocular examination, there was copious yellowish discharge from both eyes along with edematous eyelid. Conjunctival congestion and chemosis were also present. However, the cornea was lustrous and clear. There was fundal glow was normal in both sides. Skin and rest of the systemic examination were normal. For that child, we did conjunctival swab for gram staining, KOH mount, and culture sensitivity. The smear from pus revealed presence of intracellular gram-negative diplococci and few pus cells were there. So culture was done on chocolate agar and a selective medium like modified Thayer-Martin medium, which we can see there were small gray-white mucoid lesions. Sepsis screening was done using blood culture. It was negative. Rest of the investigation, VDRL, RPR, HBS antigen were all negative. Endocervical swab of mother and urethral discharge from father also confirm the diagnosis, and it also shows gram-negative diplococci. Treatment, we started with the saline lavage every 2 hourly till we could see the discharge in that child. Injection cefotaxime 150 mg IV BD was started. Eye drop azithromycin was given 2 hourly in both eye. Eye ointment azithromycin thrice daily in both eye. And child usually showed improvement in 7 days, in around 7 days. Parents were sent to STD clinic where they were started with kit 1 and kit 2. Discussion. Child presented with thick profuse mucopurulent discharge and tense eyelid edema with marked chemosis, and the symptoms subsided after 5 days with medical treatment. Infected women should be treated during pregnancy and should be retested after treatment to ensure therapeutic success. Without preventive measures, gonococcal ophthalmia neonatorum can occur in 30 to 50% of infants which are exposed during delivery. Conclusion, this is a medical emergency, require immediate hospitalization. If left untreated, can lead to severe visual complications, and it can be like prevented in 3 ways, like if we go for selective treatment of expectant mother via prenatal screening, blanket prenatal antimicrobial treatment of all expectant mother, as well as postnatal application of prophylaxis to all neonates within the first few hours after birth.